Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Randomized Phase 3 Trial of Weekly Paclitaxel compared to Weekly Nanoparticle Albumin-Bound Paclitaxel or ixabepilone with bevacizumab as first-line chemotherapy for locally recurrent or metastatic breast cancer, the CALGB 40502 NCCTG N063H trial by Hope Rugo and colleagues. My name is Kathy Miller, and I'm Balve Lantero Professor of Medicine and co-leader of the Breast Cancer Program at the Indiana University Melvin and Bren Simon Cancer Center in Indianapolis, Indiana. My oncologic specialty is breast medical oncology. Patients with metastatic breast cancer share one simple goal. They want to live as well as they can for as long as they can. Meeting that goal requires negotiating a sometimes difficult balance between maximizing control of the disease while at the same time minimizing the toxicities of our therapies. It's not about trading quality for quantity. It's about paying attention to both and recognizing that both the disease and sometimes the toxicities of our therapies can have profoundly negative effects. Paclitaxel has become a mainstay of treatment of breast cancer, frequently incorporated into adjuvant therapy, and a common choice for initial therapy in the metastatic setting. Despite its effectiveness, cumulative peripheral neuropathy, the need for steroid premedication, and the eventual development of resistance are real limitations. The development of newer microtubule agents provides needed hope for improvement. Nanoparticle albumin-bound paclitaxel could be administered without steroids and had superior efficacy compared to paclitaxel in previous randomized phase 2 trials. Ixabepilone retains activity in taxane-resistant diseases and model systems and is a more potent inhibitor of microtubule dynamics. Both, it seemed, would offer an improvement over cremophore-based paclitaxel. The CALGB, now Alliance, Trial 40506 was designed to test these microtubule agents head-to-head, all combined with bevacizumab. So, did the new agents improve progression-free survival compared to paclitaxel? The simple answer is no. PFS with paclitaxel was 11 months, exactly as predicted based on the ECOG 2100 trial, compared to 7.4 months with ixabepilone and 9.3 months with nanoparticle albumin-bound paclitaxel. The more interesting question is why not? Let's consider the possibilities. First, no matter how striking the p-value, we must always consider the possibility of chance. While possible, that seems unlikely in this large trial with broad participation. Second, this trial was designed and largely conducted in the bevacizumab era, with 98% of patients receiving bevacizumab concurrently with the randomly assigned chemotherapy. Could there be a differential interaction between bevacizumab and the varying chemotherapy agents used in this trial? Again, while possible, no laboratory or preclinical data suggests such a difference. Perhaps the newer agents are simply less potent. Again, that seems unlikely. Preclinical studies found ixabepilone to be more potent, and at its core, nab-paclitaxel is just paclitaxel. The nanoparticle albumin-bound formulation eliminates the need for cremophore and the resultant need for steroids, but the active agent is still paclitaxel. Perhaps the dose and schedule of the novel agents were suboptimal. The nanoparticle albumin-bound paclitaxel dose was selected based on a previous randomized phase 2 trial that explored various doses compared with paclitaxel. In that prior effort, the 150 milligram dose had superior efficacy compared to lower doses, with little difference in toxicity. The ixabebolone dose was chosen based on data from prior phase 1 and 2 trials, but was less well studied. Gennari and colleagues provided important insight in their meta-analysis of trials comparing longer versus shorter duration of chemotherapy in the treatment of metastatic disease. The trials had significant differences in design. Some compared a set number of cycles to a strategy of continuing treatment until progression. Others compared shorter to longer, but still arbitrary number of cycles. Despite those differences, there was a clear improvement in progression-free survival and a small improvement in overall survival with longer duration of therapy. With that in mind, let's consider the toxicity data from CALGB 40502. Both novel microtubule agents increased toxicity, leading to a significant attenuation of therapy. By cycle 5, a time point before the median PFS for any treatment arm had been reached, half of the patients in the nanoparticle albumin-bound paclitaxel and ixabebolone arms had discontinued therapy, compared to only 29% of patients treated with paclitaxel. If longer duration of therapy leads to longer PFS, this is a problem. So where does that leave us? In a sense, back where we started, with paclitaxel as the preferred agent for most patients. The newer microtubule agents are not better, they are more toxic, and they are markedly more expensive. Nanoparticle albumin-bound paclitaxel may still have a role in patients with major contraindications to steroids. Ixabebolone may still provide benefit in heavily pretreated patients. They simply haven't earned a more preferred spot in our therapeutic armamentarium in the first-line setting. CALGB 40506 reminds us of some other important lessons that are not unique to these agents or this trial. First, preclinical data can't adequately model the delicate balance our patients seek. Mice don't complain of fatigue and neuropathy, but both can be limiting to patients. Second, phase 2 trials are just that. Previous randomized phase 2 trial comparing paclitaxel to nanoparticle albumin-bound paclitaxel provided justification for the conduct of CALGB 40502, nothing more. By their very nature, randomized phase 2 trials are prone to error and can lead us astray if we fail to recognize their limitations. There is simply no substitute for a well-conducted, appropriately powered phase 3 trial. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.